Welcome to Engage Africa Foundation Festival. And on this section, we'll be talking on community action for public health, how they were created, and how they got people to participate and the impact thus far.
Much Fidelina once again. We are going to start the interactive section now. And I think we have the opportunity of throwing the first question to you. Then having gone through your bios and your growth over the years, we would love to notice that you rose through the ranks with AMREF Africa. It's closer to a decade now. Can you briefly summarize the journey for us? Thank you very much.
It's been exciting. It has been a very challenging as well as eye-opening period for me. Just interacting and intervening for the adolescent
Thank you very much for your thoughts. In fact, at least it has been a very great journey. And thank you very much for impacting the youth within your immediate environment. And subsequently, we still ask more questions about that. I would like Kenny to please go ahead with the question.
To improve the lives of disadvantaged people in Africa, what are the key areas of concern?
Thank you, Kehinde. So it is a good question. And one of the key things that I have experienced, and especially in the country where I come from, Kenya, is that for the country to really deliver health to the marginalized, to the people in hard-to-reach areas, to the people, the citizens who really need quality health services, is that we need, one, to have very robust health systems. And when I talk about robust health systems, we need to focus on all the 9 pillars of the health system. When we talk about human resources for health, there is a lot of shortage of healthcare professionals, not only in our country, but also in our continent. And it is for the governments to really put structures where we can have very high professionals who can deliver high quality health, so that we say that the health outcomes are quite improved. Secondly, we have to factor in the issue of health information, especially the health information systems, where we will, of course, be generating a lot of evidence and researches to improve the kind of knowledge, the kind of learnings that you're having. And it is for governments and also the different stakeholders to really put together mechanisms and institutionalize different pathways where the information that you're generating from our health system is quite robust. The data is optimum so that it can inform policies, it can inform programming, it can also inform generation of innovative evidences that can support the health system. Thirdly, I will also beseech the governments, and more so also working with the partners and the different stakeholders, to really focus on providing technologies, drugs and products that can really support the issue, the big issue of addressing the drugs issue. Why I say it's because most of the African countries, you'll find that manufacturing drugs is really small scale, and we need resources, we need time allocated towards the health systems really supporting manufacturing of drugs which are relevant and also contextualized within our systems, and addressing the different.
Well, we're able to learn that you also design maternity wear and.
You know the idea of the maternity wear and the breastfeeding outfit is to encourage breastfeeding and ensure optimum outcome for maternal and child well-being. Because it's not just providing medical intervention that encourages better outcome. There are other factors. Better outcome. There are other find out that some women can't breastfeed in the public because of what they wear. But they say if they have office wears wherever they are without having to expose themselves or making other people uncomfortable, then encourages them to breastfeed anywhere, anytime. So it was just for me, it was just trying to tackle the mother and child's well-being from different angles, as much as possible, from fashion, from nutrition, from healthcare, from research. That's basically it for me.
Okay, great, well done. Thank you for that. So let me go for your first question. So I want to ask, why did you decide to go into maternal health and child health? So what even prompts you into maternal health and child health, and what are the impacts of your work so far?
Well, it was in 2009 while I was doing my first degree in Nigeria that I stumbled upon the statistics of maternal and infant mortality in the country. And it was so heartbreaking for me that Nigeria contributes to the highest mortality rate in the world. I was studying something totally different from healthcare. I was doing mass communication. I just couldn't shake off saddening statistics that 166 women and girls died daily in Nigeria from maternal child health. That was actually what prompted me to say, what can be done about this? Because I love pregnancy, and I was thinking that even though I wasn't a mother, the same fate might await me when I decide to become a mother. So I like, if I get there, let me start doing things I can do to help people that are dying now. And that was what really led me to the work. And based on WHO's findings, realized that access, cost, location, poor health systems and all are the reasons why health systems are very high. So I decided, okay, what can be done in practical terms? And that's what Calabria wants us to do. We're taking healthcare, skilled healthcare to settings where they don't have access to health-seeking behavior. It's a normal thing in Nigeria that people don't have health-seeking behavior for different reasons. So the idea is that some people feel that, okay, I don't need to go to the idea is that some people feel that, okay, I don't need cultural, I need they need healthcare. So what do we do? Take this out just take them from we set up settings in communities that communities that they don't speak the regular language, communities that have a lot of young mothers like teenage moms, communities that don't have infrastructure. I mean, Nigeria is poor, but some people are really poor. And then we take vaccinations to them. When they do complications, we take them to facilities provided by government, to fundraise, that times that children are not being fed and nourished, that they find a way to get formulas, every kind of intervention, just to make sure that and babies survive. Especially the very high-risk ones and the poor marginalized ones. So far, we've been working since 2016 only, and we've reached more than 3,000 mothers, and we've been able to save babies and even vaccinations, even contraceptives,
Wow, well done. Well done for your work and the impact you are making. Okay, welcome back, Fidelina. We lost you due to the network. We were asking if we can hear you. And we are hearing you loudly. So I think I'll give you time to finish what you're saying.
Sorry about that. I hope I am audible. Great.
Yes, I can hear you now.
Yeah. So So we were talking about the pillars for health systems that the government, including the Kenyan government, should really prioritize. And I had mentioned about the human resources for health, ensuring that that gap, the shortage of health workforce is really met, because you will realize that here in Kenya, for example, in the adolescent and young people SRHR space, that a majority of the health workforce is not equipped, is not capacity built to really provide adolescents and youth friendly services. Whenever the adolescents come to the health facilities, most of the times you'll find that the facilities are not really ready for them. And if they are ready for them, then it is at hours that the adolescents or the young people are not available to take up these services. Then there is also the issue of the health information systems that I had initially said, that we need to have systems, robust systems that really inform decisions, inform policy development processes. And what we have done as an organization here in Kenya, being Amref Health Africa, is that we are supporting the national government and also the county governments to really have and utilize the data and the information that is coming out from the DHIS, that is the main health information systems here in Kenya, and also complementing it with other health information systems that are robust to provide data that is credible and can be utilized by both the Ministry of Health and also stakeholders within the health sector. There is also the issue of service delivery. So here in Kenya, health is delivered. We have the national government that is mandated to support policy and policy development and also regulatory roles. And then we have the county governments where the health department at the county is mandated to ensure that service delivery is really up to standard and of high quality. And so service delivery, of course, is quite important, looking at the fact that we have different approaches towards demand creation for the different health services, and also how this demand is supported or is met at the supply side, where it is at the facility, where the communities, including the adolescents and young people that I work with, are able to access quality health services. There is also the other thing that I had mentioned about access to essential medicines, where governments really need to put resources and prioritize to have local manufacturing of medicines and drugs and technology that can really support the needs of the citizens, and more so for the adolescents and young people. Reproductive health, because in our African setup is that we have the scientific medicines, but we also have the traditional medicines that most of the times, especially in rural areas, you'll find that it's most of the communities really access the traditional medicines. And so it is for the government and also stakeholders like Amref to really support such kind of initiatives and ensure that the national government is able to regulate the space where, like for the traditional medicines, and communities are able to access really high quality medicines and drugs that are scientifically proven to be okay. And then the other thing is about financing. Yes, we know that, for example, like in Kenya, the total budget for healthcare is not up to standard or according to the recommendations given by the WHO. And so we are supporting the efforts that are being put up by the Ministry of Health, by the government at the national level and also at the county level, so that we can as well contribute to those efforts where health financing is really prioritized so that it can have the health system moving and also working for the citizens. Then also the issue of leadership and governance. And we have adopted as an organization to the leadership management and governance, where we closely work with the county health management teams and the sub-county health management teams to really support them to lead and to manage the resources that have been allocated in the health system or the health sector, so that it can really optimally work for the system in terms of also ensuring that access and coverage and also quality and safety is prioritized within the health system, so that now we move into ensuring that we are achieving the goals and also the outcomes of the that have been laid out by the government and also us as partners contributing to those improved health outcomes. Yeah.
Yeah, that's great. Awesome. Well done so much. I would just like to follow up of what you said, where you talk about the people in the rural area, people living in the community where they also have their own alternative medicine, which they know if they don't want to go for the scientific medicine. Here in Nigeria, we have the popular one where we call Agbo. Agbo is a local concoction that communities take and they believe in it and it cure them. But the issue that I think we have here with it in Nigeria is that the same concoction or the same traditional medicine, the person or the owner or the person that is creating it will be saying is solving multiple, it can cure multiple diseases or it can do multiple work. So how do you see it, and how is AMREV is helping people in the rural community or the people around there? They are still using, because we still have people. We have people even here in Nigeria, they are using the traditional way for their healing and for any sickness or disease they have.
Yeah, thank you for that. I think one of the key things that AMREF has been doing, and not only in that alternative medicines area, is that we are closely partnering and collaborating with the health management teams, especially at the county level, where the role of the counties is to provide services and high quality services. And so what we do is that we closely work with the counties to ensure that the counties are also including the communities, because these alternative medicines are at the community level and are not regulated most of the times. And so the counties are able, we closely work with them so that we can empower the community, we can sensitize the community about the medicines that are scientifically and are to standard to the scientific regulations and standards. And so we ensure that the communities are aware and they are sensitized so that they can access services and medicines at the health facility, because that is where they will access quality health services and also access the medicines and the drugs that they require to ensure that they meet the needs and also cure the diseases that they are having. So it's about ensuring or mobilizing the communities through all the structures, the community level structures, so that the community person, the community member, at whatever cohort they are in, is able to have information and use that information to make a decision about their health and also where to access the service that they need.
All right, thank you. So I would like Samuel continuing from here. Samuel, you need to unmute yourself.
Yeah, okay, sorry. Thank you very much, Fidelina. But my question goes to Rebecca. Please, why is interacting with us the other time, you talked about you going in for mass comm, then now coming down into health now. Please, how are you able to kind of bridge the gap between mass communication and health now? Because I believe child and mother mortality is all about health. How are you able to bridge the gap? That's the first question. Then I need you to kind of use that to answer the main question, that what are the challenges you have faced working in this particular sector, coming up with Labiamo Foundation? Tell me the challenges you faced and how you were able to kind of overcome them. Thank you very much.
Okay. First, for how I was able to switch from mass communication to to healthcare. So I remember when I came up with the idea of doing the my project. I remember my HOD then asked me why I wanted to switch from mass comms to healthcare, considering the fact that there's no relationship between them. And then my supervisor told me to tell him that mass communication is the medium, healthcare is the message. I mean, mass communication is all about passing a message across. So I was just using my skill as a mass communicator to, to raise like an awareness around the challenges of maternal and child health that people are not aware of, that people are oblivious to. And that has guided my career choices up until this very moment, because when I was doing my first degree, I worked in an orphanage just to understand, like, because I was trying to shift from mass communication to maternal and child health. So I spent like a year in an orphanage. I learned some things about the basics of whatever, and then built experience in that respect before pursuing a master's in maternal and childhood studies. And then my focus during my master's was actually doing research on twin pregnancies and impact on child development. So, and gradually I shifted, and I keep shifting. And I'm working towards building a career and a professional career now in social work, focusing on family and children. So for me, it was one step at a time. From that moment, I discovered statistics. I didn't just do it drastically. I was step at a time, more professional education. It was one step at a time. And once step at a time, I get the first experience, I launch in, and then when I see something new, deviate again and more, just taking me deeper and deeper. So really, there's really no clear cut, because there are a lot of multidisciplinary involved in matters. Child health is actually a medical person. There are other services that are rendered that still determines the impact.
I think our network.
Yeah, I think our network is not that good.
Sorry for the interruption.
Yes, sorry. Yeah.
Okay. So, and then back to the challenges. The major is strictly free. We don't charge income, because already these people they are bent on their ways of seeking yalago and concussion and taking their deliveries themselves. So they won't even want you. So we consistently go to the issue of funds to get medications, to get skilled people to work, to get formulas in some cases, to get other interventions, to connect the dots to the government. Because what we're doing again is that we are connecting the dots, taking these people from their communities into the government facilities when need arises. So funds, we struggle with the challenge of getting skilled hands. Most of the sectors where we work are not so the setting where we work are not. Can you hear me?
Yes, I'm with you.
Yes.
Hello.
You can continue.
I'll continue. I'm with you.
Hello.
We are with you.
Hello.
Can
you hear me?
We can hear you clearly.
Yes.
Okay. So, and then yes. Okay. So secondly, like I said, we go through the challenge of skilled workers. Most of the settings where we work, they are not nice. They are slums, like the core of slums. and you find out that the skilled people find those places very disturbing and too dirty for them to step into. A lot of them are willing to work with us during the dry season, but when it rains and we face flooding, they might want to come because they feel that place is too dirty, it's too. I cannot travel on boats. There's no life jackets, So it's just all year round, And then we struggle with some of the things. There's some dots that the government is supposed to connect for us that they don't connect. Say you meet a woman or a pregnant woman or a teenage girl with complications. Don't invite this baby because if you do, might die. The baby might die. And then they get to the primary health centers when they are open. They tell them they did not speak the language and understood, or they are telling them because they are not registered there, you cannot take delivery. Different challenges like that. As each need arrives, personally, I just have this philosophy that what's the way around it, somehow we are still going. It might just be that we have to reduce some services or maybe some events. We don't give the full-fledged intervention that we would have loved to give.
Okay, I think she's still having
the network challenge. Well, in summary, I think I was able to hear her. She was talking about our experience in terms of getting in internship, working with people, working within orphanage, doing a standard study. That has made her to gain the experience in which she's currently using now.
I think she's back.
Yes. So Rebecca, in summary now, are you hearing?
Yes, I can hear you now.
Yes, I said in summary now, that means you gain experience from internship, from understanding orphanage homes, and likewise talking with the people. That has been the focal points behind your success as far as Labiamon Foundation is concerned.
Please, can you repeat yourself? I didn't hear you clearly.
Yes.
Sam, you need to unmute yourself.
Hello, sorry, are you hearing me?
Yeah, I can hear you.
Yes, I'm trying to of what Rebecca is saying, that in the nutshell that our progress thus far can be attributed to the fact that she was able to network, she was able to gather experience from orphanage homes, and even with her background of mass communication, was able to use that as a pilot for us to project the issues concerning mother and child. And likewise, she mentioned the fact that some of the challenges she's currently facing is the fact that, okay, the issue of lack of funds and the issue of the skilled workers now saying the environment they intend to get to, they are not really favorable for them. By so doing, they have to shy away from taking responsibilities.
All right.
Yes, please. Yes. Yes, in summary, yeah.
Okay. Yes, that is summary. Thank you very much.
Okay. Thank you, Becca, and thank you for the wonderful work you are doing with our mothers and with the children, even though he's in slums places and you are still working and giving hope to people. So if you are still with us, we are talking about community action for public health and how they were created and how they got people to participate and impact they have made so far. And with us, we have Fidelina and Ndunge, and we have Afolayan and Rebecca. And now I'll be taking directing my question to Fidelina. I want to ask that in what way do you think you can work with NGOs like us, Engage Africa Foundation? In what way do you think you can work with NGOs like us in sensitization, eradication, and the management of NCDs, not communicable diseases? Thank you.
Thank you.
Thank you for that question. So AMREF is very keen on partnerships with like-minded organizations who have a similar vision, more so in eradication of and minimizing the NCD cases in our settings. And AMREF is actually an international organization, and we work in multiple countries here in Africa. And so partnerships being one of the key agendas for the organization, and also looking at the fact that we are also anchored on the SDG for partnerships, is that we are always looking at opportunities where we can collaborate with organizations that are youth-led, because yourselves, you are a youth organization. I have checked you out. Your team is also a very youthful team. Looking out at also the fact that our continent is very youthful population. Our country is a very youthful population. And so for us to take back the tide towards the NCD that we are having or we are experiencing as a country, is that AMREF always looks at the opportunities to work with local organizations, capacity building, these local organizations. We have one of our models that we have created as an organization that is called the Organizational Development and System Strengthening, where we not only work with these local organizations or like-minded organizations, but also capacity build their systems so that they are able to technically work with the communities, be relevant, and really reach the need of the communities that we are targeting. At the same time, looking at the fact that we need to grow as an organization. So aspects on advocacy for prioritization of the different needs that we have for the NCD's programming. There is also the issue of resource mobilization, looking at how the health financing can be progressed towards achieving or contributing significantly to the NCD programming within the country and the continent, and also ensuring that the governments are able to put in resources and finances, whether it is domestic financing or looking for traditional donors. There is also the new donors or diversification of the resources and income bases that we are always looking at, so that we can support more and mass NCDs programming. And so we also look at organizations that are quite strong in terms of community systems. And by that, we are looking at opportunities where we can strengthen the community systems, whether it is working with the community health workers or volunteers, equipping them with the knowledge, with the skills, so that they are able to identify any signs and symptoms and respond to such issues at the community level or at the household level, so that they are able to refer in a timely way all these NCD cases to the health facilities, or even when the patients or the clients are referred back to the households, then the community health workers are able to continue with home-based care to support the patients and the clients to be able to really have better health outcomes at the community level. At the same time, looking at the fact that there is a lot of myths and misconceptions, especially about NCDs. And so we closely work with the community structures, whether it is young people who are social influencers, who can use social media to really pass correct and factual information about NCDs, and at the same time as they pass or create awareness through digital platforms, they are also able to provide data and report and information of really what is happening on ground, and magnifying the narrative in the community, and using the social media platforms and digital platforms to do digital advocacy, whereby the policy makers and also the duty bearers are able to really get to understand what really are the needs of the community and what is really affecting them in the space of in that aspect of closely collaborating partners and also community structures, both digital platform level and also non-digital approaches. And one thing also that we have done as an organization is that we use a lot of human-centered design to design solutions with the communities or with the members of the community, design with them, test these solutions with them, and also try to ensure that the solutions are desirable to them, are acceptable to them, so that now they are able to sustain the impact of these solutions and interventions that we are designing with them, because health is a responsibility of every community member. So if we can empower the community health structures and work with them through the human-centered design to come up with solutions that are relevant and acceptable and desirable to them, then we will ensure that the communities are able to own the entire process and hold accountable the duty bearers who are supposed to prioritize their needs as community members to eradicate the NCD issue.
Thank you, Fidelina. I like the part where community people take the health of their community people very serious, but also amplifying it using the online platform so that relevant government or stakeholder can take action with it. Well done. I think now we'll go back to Rebecca, and I think Samuel, you have a question for her. Do you?
Sorry. My next question goes to Rebecca. So what are your advice to young people, especially women, that intend to follow your footsteps?
Rebecca, are you there?
Rebecca, are you there?
Hello, I'm so sorry. Rebecca, I didn't get the question, please. I didn't get the question, please.
Yeah, let me try to rephrase. I said, what are your advice to young people, especially women, that intend to follow your footsteps?
Oh, okay.
I hope you get me now.
Hello, Rebecca, are you there? Okay. I think maybe she's having issue with the network.
I'm so sorry. You said that advice to young people that want to follow my footsteps. Did I get the question right, please?
Yes, that's the question.
Okay. I think for me, my philosophy is there are a lot of problems in Nigeria. Let me start with Nigeria. There are a lot of problems in Nigeria, and there are a lot of problems in Africa. And the countries where we have development, it's not one single person making it work. It's multiple people identifying different aspects of challenges in their country, and facing it based on what they are passionate about and what they are skilled in. So my advice to young people, just like I have woken up to maternal and child health issues in Nigeria, despite the fact that I'm not a mother yet, other young people should open their eyes to challenge their area. To understand that they are passionate about. They don't even have to have experienced it, and they might experience before they wake up. But if we can all identify different issues at different levels that relate to our passion and our concerns, and address those things in any little way we can, I believe the country will be a better
Thank you very much. So it's all down to passion and be able to get in touch with the immediate community about what are the issues over there. Thank you very much for your thoughts, Rebecca.
Okay.
My next question.
Okay, go on, Samuel.
Fidelina, are you there? Fidelina, are you there?
Yes, I'm here.
Yeah, the use of tobacco, the use of alcohol, then unhealthy diets like maybe food high in fat or processed sugars are some of those things that are contributing factors to non-communicable diseases and are most taken by the youth. And you as an individual working in reproductive health, because I am very sure of the fact that you are aware that some of these tobacco, the abuse of tobacco, the use of alcohol, food high in fat, and so many other things are some of those, they are also implicated in reproductive health. So what are the measures, what are the programs that you have in place to stop the youth from taking much of these substances that are kind of injurious to their health? Thank you very much.
Thank you for that question, Samuel. So what we have been doing is that when we are talking about, or when we are engaging the adolescents and young people in our reproductive health programs, is that we integrate the reproductive interventions with other key health messages. For example, the issue of alcohol and drug abuse. And what we do is that we use the life skills education approach, where we combine the reproductive health topic areas like HIV, how alcohol abuse contributes or is a risk factor towards an adolescent or a young person really having a reckless behavior, and as a result, them acquiring or getting infected with HIV, AIDS, and other sexual and reproductive health issues. And so we usually combine through the life skills education to really empower the adolescent, not only in their health needs, but also in their life skills. How can they negotiate better? How can they not communicate better or not be peer influenced by their peers or their friends for them to indulge in tobacco and alcohol abuse and also drug abuse. And so we usually empower the adolescent in a holistic way to be able to make better choices, health choices that are adding value to their bodies. Something else is that we are closely working with other organizations and alliances where we can really push for the voice of eradication of the NCDs by ensuring that the sugars, the tobacco, the alcohol is really taxed, so that the government is able to really regulate also the use of these different items. The other thing is that whenever we are discussing or engaging the adolescents and young people, and one thing that I know also you guys in a supermarket, you'll find that the lower shelves in the most of the high sugar products are actually placed there, or where at the cashier level, the high sugar products are placed there so that children, young people are able to really see them. It's a strategic place to really put them up so that people are able to see them quite faster and pick them, not realizing that these products are going to have implications to their health and predispose them to NCDs. And so what we do is that during this life skills education, we are able to really educate the adolescents and young people to identify these products and also read the products, the ingredients of the product, so that they pick the healthier products that are ensuring that they have healthier diets or are really good to their health, and leave the high sugar products. And so it is a mix or a balance of providing the SRHR messaging, but also integrating these SRHR messages with other life skills messages in terms of communication, negotiation, and them not being influenced by their peers to really indulge in tobacco use and also alcohol use, and also to say no to some of these influences from their peers.
Okay, thank you, Fidelina. Thank you for your work. I would like to direct my question to Rebecca Afolayan. In your work, collaboration is very key to and essential to maximize profit or gain or success in what someone is doing. And your work as in Alabiama Foundation, what are the collaboration, or what are the maybe people that have joined or come together to work with you, and what are those collaboration as brought or given about to for Alabiama Foundation?
Okay, from time to time, we've had individuals, we've had organizations, but the ones that have been consistent over the years is Rotary International. We still constantly work annually with Rotary in Lagos Rotary. And there's another one, there's a virtual Rotary with they are based in London. They bring resources to us, from treated mosquito nets to malaria testing kits to formulas, diapers, baby essentials, donations from time to time. We have other non-profit organizations that we work with. There's one they call No One Left Behind. They focus on sickle cell, but their interest in maternal and child health has to do with malaria. So we collaborated with them last year. We work with local governments too for vaccines. So any community where we are working, we collaborate with the government, local, because we can't store vaccines and we can't receive vaccines directly from donors. So we collect vaccines from government facilities, and then we do the outreaches and return reports back to them on a monthly basis. We have other individuals who have their own and then they make their, like, maybe in the form of annual return, quote and unquote, and they pay into the foundation for us to keep running. There's a midwife that's just left us. The name of our organization is called Repro Life. So what she does is contraceptives. So she's one of the midwives that work with us in communities, to give skilled healthcare and then contraceptives to women. There's one called Tolu the Midwife. Tolu the Midwife too. She does maternal and child health, but she focuses on the rich eyebrow people in Nigeria. So she takes research from the eyebrow to give to us that are working at the grassroots level. Then we have PSN Africa. PSN does maternal and child health, postpartum depression for maternal and child health. So they come into our settings once in a while to try and talk to the women about postpartum depression. There's one called Ediko and Amy. Unfortunately, they lost their founder last year. She was a doctor. We collaborate with them too, whenever they have outreaches to go into communities that the kind of community we serve. I go to give health talk and help them with some interventions that are similar to ours.
Okay, great. So I would just want to have another question for you. I just want to know, how are these communities? How are they? Are they welcoming, or how are they accepting your work? How do they see your work? Do they value your work? And how do you two also support the communities? I don't know, maybe when you go to a community, do you, apart from the training, were you able to, maybe out of the community people, have someone that can do what you are doing even after you've left the community?
Okay, because we know our interventions are not for, it's not a touch and go. We don't have a touch and go approach, like just do makeup and then go. As like once we enter a community, we stay, and we want to build something that lasts over the years, like, you know. So our community work are driven by community people, because we, the health workers, are not living in those settings. We only come once. Before COVID, we were going twice in a week, in a month, but now because of COVID, we only go once a month. So they can't rely solely on us. So we have other community volunteers and community mobilizers that that have been trained. So you see someone with malnutrition, or you see someone battling, a baby battling diarrhea, or you see someone who is in labor and doesn't know where to go, or you see a child that is not thriving. So we already have those kind of settings. They've been trained to identify those things. And then if they feel they cannot take the person to the health center, primary health center, when we are not there, they call. The recommendation or treatment that can be given over the phone, we do. The ones that cannot be given, we tell them, okay, you know where to take this person, take them to the health center, or you look for a traditional birth attendant. We also work with traditional birth attendants in this setting, because of course, most of these communities are not easily accessible. In fact, in all the communities where we work, you cannot drive into them. You are going to trek. The only thing you can use is cycling. You can use bicycles, but it's not really often. It's not common for you to see bicycles in these settings. What you see people trekking into it, walking around. So what we do is, we know we cannot prevent them from using traditional birth attendants, because those are people that are available at night when they go into labor. So we have a few traditional birth attendants in each of these communities that we already work with, that when they take deliveries, we tell them, okay, bring them for vaccination, or tell the mother of the baby you just delivered to bring the baby for, or even after they've taken delivery, it happens to be days when we are holding events, they'll bring the babies as soon as they're born for vaccination, and then we give them, there's a recommended vitamin A dose vaccine that we give to new moms too. So there's like a collaborative work. One of the communities where, in fact, the place we've been the longest, the community people have come up to give us the land to build a facility for them to be having delivery. And they've also given us the set. So most of these communities, we actually use either churches or primary school that are built by the community, or the ballet's house or something. So we don't have facilities, but they give us facilities owned by the community. We keep our items that we use there. And then they are the ones that do the mobile. Aside, most of them don't have mobile. Their homes are not numbered. So you can't say she lives in it's from one, and their pastors and their ballets and their contact. So we work from time to time to say, okay, this woman has addressed it. We need to meet her partner. Can you take us to the partner? How we work? It's like a collaborative work with the community. It's for them, and it's to improve the well-being. So that's kind of how we work.
Okay. Thank you, Rebecca. Thank you for your work. We know the kind of work you are doing is have to do with the passion someone have with it, because going to a community where there is no even social amenities, even in that community, it take passion and take even love and care for the community, and the work you are doing even for the nursing mother and for the children, the little children, really appreciate. Say thank you and well done. So for our audience, we are still on we are discussing community action for public health and how they were created and how they got people to participate. And to participate in this session, you can drop your question, and you can also follow the conversation even after this session. You can drop your question on the social media. You can tag even our panelists, even on their social media, in your question, and they can go further and give you more answers to those questions. And as we are rounding up, so I will ask Fidelina this question. Public health focuses on improving and protecting community health with key emphasis on prevention. How has it been in combating or preventing Lassa fever and preventing a reemergence of coronavirus in local communities in Africa?
Thank you. As you put it right, I think prevention is better than cure, and so for the health system really to work optimally, there is need for a more focus towards prevention. And prevention, we have to closely work with the communities, empower them, capacity build them to be able to really take care of their health and to prioritize health as their responsibility. And so some of the key things for AMREF, what we are doing is that we are really focusing on behavioral interventions, the social behavior interventions, and more so that we engage the community health workers who are able to be capacity build and to be trained. And so what we did when, I'll give an example of when the first case of COVID was reported here in Kenya, is that the Ministry of Health at the national level and also at the county level is, or what we did with them, AMREF collaborated with them, and we came up with structures of community engagement so that we can have every stakeholder being coordinated better to respond to this pandemic. And what we did is that we formed or we plugged into technical working groups to task forces to respond to COVID-19, and ensured that every cohort at the community level is really responded to in terms of equipping them, creating awareness about COVID-19 IPCs, and also at the same time closely working with the communities and identifying opportunities to ensure that the communities themselves come up with solutions, and also messaging that is relevant to them taking up preventive mechanisms that will prevent them from really getting infected from COVID. So we, at the national level, we created and supported the Ministry of Health to form a national level community engagement working group, where at that level it was coordinating the entire nation in terms of what are the priority interventions and activities that are going to reach to masses or to the population, so that we are able to really change our behaviors and our attitude towards prevention of COVID infections. And so at that level, we were able to bring on board youth-led organizations, community health volunteers, were able to engage influencers, social media influencers, and also influencers that are relevant to specific cohorts. So for example, if it is the adolescents and young people, who were able to bring on board youth influencers who can start creating awareness through music, through social media awareness, through spoken words and the like, very artistic social behavior interventions. And then also at the same time, we were able to really talk to politicians so that they're also able to influence their followers and their fans to be able to take up and to practice behaviors that are going to like lower their exposure towards the COVID-19. Then at the county level, we cascaded the same groups, the technical working groups, the task forces, and ensured that they are multi-sectoral so that every other sector, not only the Ministry of Health, is really responding to this pandemic. We brought in the Ministry of Education, we brought in the local administration, the religious leaders who are now able to come together to the table to discuss about the different strategies that are going to be supported by the county so that we can reduce the cases and also the high infection rate for COVID at that point. Then at the community level, the community health workers were able to be trained both digitally, like for AMREF, we have one of the digital platforms that we really use countrywide in all the 47 counties. It is called LEAP, and we were able to train the community health workers to respond fast to COVID-19. They were able to be given the key messages for COVID prevention so that they can pass the same messaging to the household level, and also we were able to closely work with the private sector, with the public sector, so that we provide support in terms of even supporting the supermarkets to put in resources to the county so that we are able to really have a basket of responding to a basket of resources to respond to COVID-19. So the private sector also came on board as a really key actor towards responding to COVID-19 and just ensuring that everybody is able to respond quite fast and well enough. Something else is that we were able to support the MOH to really revise some of the guidelines, health guidelines, like for example, the reproductive, maternal, newborn and child health guidelines, so that the guidelines are able to really give direction on how to respond to the RMNCH needs during the pandemic period. We were also able to support the MOH to also come up with guidelines of how at the community level the CHWs are supposed to really respond to the COVID-19. And so it was a journey, but a very challenging and really fast-tracked journey for us to really learn and iterate on some of the key insights that are coming out, and also ensuring that we are generating a lot of evidence on what is working, what interventions are working that can be replicated to respond to COVID, and what is not working. Something else is that we during the evidence generation, which we have done continuously, is that we were looking at how the pandemic has impacted health outcomes, how it has impacted social behavior of adolescents and young people, and also the rest of the population, how also economic activities have been impacted by the pandemic. And so based on this evidence that we generated during that period, we were able to really design interventions that are based or also informed by evidence that is being generated by AMREF and other actors to have interventions that are relevant and are also meeting the current needs of the population. And so we, like for example, some of the key things that came out in the health space, particularly for the adolescents and young people, is that health was disrupted, and they were not able to really access adolescent and youth-friendly services because there was stigmatization of, if I go to the health facility, I might get infected. And also at the same time, all focus at the health facilities was shifted towards responding to COVID. And so all these other essential health services were sort of left or overlooked. And so some of the needs were not really met for the different population or the targets that we were initially working with. And so what we did is that based on this evidence, we were able to really focus on community enriches at the health facilities, so that also the young people or the community members are able to really access the services, the other essential services. We were also able to have models like booked-in clients, where the community member would call that specific healthcare worker at their preferred health facility, and they would book particular time when the professional, the healthcare worker, is able to meet them. And so we, through those kind of models, we were able to continue with the provision of the essential services, but also at the same time respond to the COVID pandemic. Also looking at the fact that we did a lot of resource mobilization, where we were integrating resource mobilizations to respond to integration of COVID pandemic, but also other essential services like the SRHR, the MNCH services, so that the mother who, for example, or the teenage girl who requires HIV testing is still able to access that service, or the mother who is pregnant is able to still go to the facility and deliver. At the same time, this health workers being able to respond to COVID at the community level, at the facility level, and also at the county level. So we categorized and grouped all these needs at the different levels so that we are able to respond to the community needs, to the county needs, so that the guidelines that we supported the national MOH can be domesticated at the county level, and just ensuring that also the national MOH is able to really get timely data, timely evidence for them to respond in a timely way, and also for them to make timely decisions that will respond not only to COVID, but also to the rest of the essential services.
Wow, that's so great and well done. I think, like you said, prevention is better than cure, and the more we prevent people from all these diseases, and the awareness, even for them to know how they can move away from all these diseases and sicknesses, it will also help. Thank you very much. And as we're just rounding up, I just want you to, in few words, I want you to just advise Fidelina, what would be your advice to young or upcoming healthcare system reform in Africa? Your advice for young people in Africa that are listening to you. Fidelina.
Yeah. Thank you for that question. And I think responding to the tag where young people, we are usually saying that there is nothing for us without us. One is to support and really encourage young people to voice up their issues, voice up the needs that we are having as young people, as young people who are also in the health sector, and be engaged and sit at the table, but not just sitting at the table. It is also up to us to really actively contribute to discussions at the decision-making tables when we are given the opportunities. And so it is for us to really be engaged. I know most of us are talking about meaningful youth engagement, but when we have the opportunity, how do we really hold our duty bearers accountable for the commitments that they have put in place, for the commitments that they have promised us? Because a majority of us are young people. The population in Africa is really very youthful. And for us to achieve the great tides or strides that we really want, our health system to really address our health needs, it's for us to really take those opportunities seriously and voice up our issues and hold the different duty bearers accountable and ensure that the systems are transparent. We are being, we are participating, we are being engaged, we are being supported to amplify our voices. And so it is for us to really identify what are the needs that we are having. When we talk about universal health coverage, what do we need to see when we talk about universal health coverage? Is it about the government being able to allocate more resources for the health sector? Is it the health financing to be increased to support the different needs of the youthful population that we are in? Is it about collaboration and participation with the government, with the public, with the private sector, so that we are able to really come up with solutions for ourselves? And so it is for me to really encourage us as a youthful population to be able to take up those opportunities to collaborate with the different sectors through the multi-sectoral forums that we are engaged in, taking the opportunity to really engage both the public and the private sector, the communities that we are in, and to be voices of the voiceless or of the marginalized people that we engage at the community level. Also is that I know that you are having a lot of challenges, but it is for us to really come up above the challenges, whether it is the social, cultural challenges that we experience or the economic challenges. I think young people, we are very vibrant, we are very passionate about opportunities for income generation, for economic empowerment, for career advancement, and for technological advancement in our continent, and also in, for example, in my country, Kenya. And so it is for us to really not sit like we are not being presented with these forums or these opportunities, but for us to really grab them. And once we grab them, we go for them and voice the issues that are really affecting us, whether health or economic or technological or social cultural issues that we really need to bring them out.
Yeah, thank you so much. I know that our audience are listening.
Yeah, thank you. I don't know if you still have Rebecca there. I have one last question for you.
I'm here.
Yeah, thank you very much. While interacting earlier, you told us that you've impacted about 3,000 mothers. Why personally, I really love your work. I really love what you are doing. I intend to ask you, how do you intend to propagate your work outside Nigeria or outside the state as a whole? How do you intend to get more people to participate in your work? Thank you very much.
We don't only work in Lagos State. We work in Ogun State. But the reason why Ogun State's work is not consistent is because there are some infrastructures in Lagos State that are not available in other states. So, for example, vaccines and primary health centers work hand in hand. The mapping in Lagos State is still relatively okay compared to other states. Ogun State, the challenge we're having is that the mapping is very terrible. And even some primary health centers that are available are not furnished. We have settings where even in primary health centers, people are delivering babies on the floor. So it's very difficult for us to connect the dots. That's why it's as if our work in other states are not so pronounced. And in connecting other African countries with a high mortality rate, we are hoping to saturate Nigeria first. But before we can even go into other states or other countries, we need more collaborations because it's capital intensive. What we are doing is taking the work of the government. This is what your government is supposed to be doing, but we are trying to do it. So, I mean, with collaborations in other countries or in other states, if you have say organizations that are willing to sponsor vaccine pickups and drop-off or vaccine storages in other states in the country, like Lagos does, it will be easy because most of all these primary centers in Lagos state government facilities have solar-powered freezer for storing vaccines. Those are not obtainable in other states. Even if you have them in other states, it's just the major cities that have them, not the local rural areas. But in Lagos, it's not the same. Okay? So with collaborations, we can infiltrate other countries. With collaboration, we can infiltrate other states. By the time we have organizations that produce vaccines and that are willing to give you solar power, we can carry vaccine anywhere in the world or anywhere in the country or anywhere in Africa. I believe with collaboration with other countries, we can actually infiltrate.
Okay, thank you very much for your thoughts.
So we want to say thank you to our panelists. Thank you for sharing your thoughts, and thank you for the time so far we've spent together. And I've really gained and learned so many things that are even new to me. So I know that our audience too, they've gained some things from what we've done. And Becca, if you're looking for a state, they have a solar panel for the vaccine. I don't know, maybe you reach out to Kwara State. I know Kwara State because I have access to the public health person in Kwara State, and I know that the state have that kind of facility you were saying in all the 3 senatorial area in Kwara State. So you can, if you still want your work to come down to Kwara State, we can collaborate and see how your work can get to Kwara State. Thank you, everyone. The final thing I want our panelists to do is can you just maybe in 1 minute just give us your maybe your social media account so that the audience can follow and ask their question after now. I'll start with Fidelina.
So my handle at Facebook is fidelina.ndunge. On Twitter, it's also Fidelina. Sorry, Twitter is at Ndunge. Is it F? No, sorry. At Twitter is Fidelina N. Then Instagram, it's fidelina.ndunge. Again, Facebook, fidelina.ndunge, Instagram, fidelina.ndunge, Twitter is Fidelina N, at Fidelina N, Twitter.
Okay, you can reach out to Fidelina in all these 3 social media handles, and from there you can drop your question, and definitely she will reach back to you. So, Becca, can you we like to drop your social media account so that our audience can drop questions?
Okay, so for me, they can reach me because I'm actually not a social media savvy person. I'm back behind the scene kind. So Alabia at Alabia or FDN on Instagram, Twitter, Facebook, on LinkedIn too. I mean, any question. There's someone to respond to questions anyway, generally on all Alabiamo's platform. But for the ones that cannot be answered by them, they would normally send it to me, and then I give my responses. At Alabiamo,
okay, once again, okay, all right. So if you want to reach out to Becca, you can just reach out to our foundation is Alabiamo Foundation. And if you want to reach out to Fidelina, our own Amprev LT can also reach out to us. So I want to say thank you to our panelists. Really enjoy your time. We know your time are also valuable to you, and we thank you for sharing that time with us. And we say with your word and with your work, we know Africa will be better. Samuel, would you like to say your
thank you
final word?
Yeah, thank you very much, Kenny. It has really been a very great section. At least personally, I've learned a lot, and I feel challenged that I need to really do more work within my immediate community. Thank you very much to our esteemed panelists. I've been a very big time, and we wish you very the best of luck as you make more impact in Africa as a whole. Thank you very much.
So thank you. This is our bye from here. Thank you.
Thank you. Bye.